And hi, I'm Kim. So I'm your backstage manager here tonight, and I look forward to watching the interaction with Matt and Dr. Maskin. I think there's going to be a lot of really great information that they share with you this evening. And thank you for being here. I'm going to, before we get started, I want to let everyone know that this Q&A is being recorded and may be used by Dr. Maskin for promotional purposes. Also, the information and suggestions contained in this presentation are not intended to replace the services of your physician or caregiver, because each person and each medical situation is unique. You should consult your own physician to get answers to your personal questions, evaluate any symptoms you may have, and/or receive suggestions on appropriate treatment. And at this point, I would like to introduce Matt Borsina. Good evening, Matt. I'm going to turn this over to you.
Thank you, Kim. Welcome, friends and fellow sufferers. When I tried to put this out there, I don't know, probably 6-8 months ago, and we've been trying to put this together with myself and Dr. Maskin, but there's been a lot of moving parts, and it's finally come to fruition, and we're so happy that I was able to get Dr. Maskin's time, who he volunteered his time and his knowledge to try and help all of us. Just want to give you a quick background on myself. Lately, I've been asked if I was affiliated with Dr. Maskin's office in any way, and I just want to give a quick bio of myself. I am an electrical contractor. I live in Long Island, New York, and Dr. Maskin's practice is in Tampa, Florida, so I have no affiliation with Dr. Maskin or his practice other than I am his patient and friend. I've been seeing Dr. Maskin now for approximately 2 years. I've been suffering with my disease for, I was close to 3 years. The first year of my suffering, I flew all around the United States, seeing many doctors, local and statewide, trying to figure out what was wrong with me. Spent a lot of time and effort and money, and really had no conclusions as to what was wrong with me and why I was suffering greatly. And I think all of us will agree that dry eye, the name, doesn't do it justice. So I was at my wit's end, and I saw an interview with a Dr. Maskin on I don't know, it was a YouTube or something channel. And it was a completely different approach to everything that I was being told. And I called over to his office and made an appointment, and my life was changed from that day forth. So I want to introduce Dr. Maskin. He was the doctor that saved my life, and I'm not embarrassed to say that. I wrote a little script, but I'm just going to kind of wing it here. But I did write something about Dr. Maskin that I'm going to read to everybody to kind of introduce him. Everybody knows the name Maskin because it's synonymous with probing, but he's so much more than that. So let me just read my little thing about him, and then we're just going to kind of let this unfold organically with me asking him questions and kind of having a back and forth with him on a lot of the questions that came in. I think we had a little over 140 people register, and there's a lot of questions. And what we did was I picked the most popular, and we're going to ask Dr. Maskin the most popular questions first off, and we'll see how this goes. Give us a little latitude because, again, I'm not a professional interviewer. And this is our first go at this. We're hoping that it'll morph into something monthly or bi-monthly or something to help people. So this is Dr. Steven Maskin. He's an ophthalmologist that specializes in solving the most difficult cases of dry eye, Meibomian gland dysfunction, and ocular surface disorders. He's treated patients from across the globe who seek comprehensive care tailored to their specific needs at the Dry Eye and Cornea Treatment Center in Tampa, Florida. He's published over 22 scientific papers on meibomian gland dysfunction.
Okay, so I like to thank Matt, Kim, and Claire, who's my research assistant, for organizing this event. You should know that the driving force behind this event is Matt, who has an incredibly big heart and is determined to help as many dry eye sufferers as he can. We only have an hour, and we do have over 140 registrants signed up submitting questions. So we'll get to as many questions as we can. If enough of you benefit from tonight's session, we can continue this in the future. My goal in participating in this event is to help each of you by pointing you in the right direction to get the help needed to successfully restore comfortable eyes. To do so, we'll begin with basic concepts. From these basic concepts, you can identify the severity of your MGD and your comorbidities. And then, identifying the comorbidities, you'll be able to use targeted treatments leading to the successful reversal of symptoms. And in my experience, this means both, or from mild disease to the most severe disease, so-called neuropathic pain. So I think that one way we can begin until Matt can catch.
I'm back here. So I had something happen.
No problem. Matt, all right, welcome back. I just finished my intro where I thanked you as well as Kim and Claire and gave some basic perspective on what we're trying to do here. So actually, we can begin with the questions whenever you're ready.
All right, did everybody get my intro or was I cut off?
Part of your intro before you froze. So
all right. So everybody got me and knows who I am. I'm Matt Borsina, in case you questions into different categories, different topics. And the first topic we were going to discuss was the diagnostics of dry eye and meibomian gland dysfunction. So one of the most popular questions are to you, Dr. Maskin, is what's the best approach to diagnose dry eye disease and meibomian gland dysfunction?
Yeah, this is a very important question, and Claire will put up an important slide. This slide is a figure from my book, which is Your Dry Mystery Solved. It's available on Amazon and so forth. But in that book, this is a key figure to understand. This figure presents the solution to reversing your dry eye problems. And the way we do that is we begin in this hub and wheel configuration in the hub itself. And the hub, of course, is MGD. The meibomian gland dysfunction is a major etiology, a major cause of symptoms in over 90% of dry eye cases. Now, in addition to examining the patient, examining you, performing tests to understand the severity of your MGD, we also need to identify comorbid diseases. Now, comorbid diseases, you can also think of as root causes. Those diseases that create inflammation that have an impact on the meibomian gland, creating inflammation and ultimately scar tissue that we describe as periductal fibrosis. And that scar tissue is wrapped around the duct wall of the gland, choking off the flow of meibum. But we'll get to more of that in a minute. But right now, understand that the comorbidities can be thought of in different categories. For example, you can see the sector of mechanical. So mechanical causes or comorbidities that create inflammation that could lead to periductal fibrosis of the glands include the most common one that I see is conjunctival chalasis, for example, which is that loose, floppy tissue of conjunctiva, which, of course, the conjunctiva covers the white of the eye, It's the mucous membrane covering of the white of the eye. And normally has some adherence to the sclera of the white of the eye, but it can become loose. And when it becomes loose, then the lid can grind over it, creating friction, and friction causes inflammation and so forth. So conjunctival colitis is important to diagnose, important comorbidity to diagnose. Lag ophthalmos, another important diagnosis, that this is when the lids do not close completely when you blink, or you may have nocturnal lag ophthalmos, which means the lids are open when you sleep. Moving on to inflammatory causes, the inflammatory sector or inflammatory comorbidities, most common there is allergies and anterior blepharitis, which of course is inflammation, discharge around the lashes and the anterior part of the lid. Over on the other side, tear-related sector of comorbidities, we have aqueous tear deficiency, again, very, very common and essential to identify and adequately treat. Analogy there is the same way that saliva is necessary in our mouths to keep our gums and teeth healthy. With insufficient watery tear, aqueous tear deficiency, that alone creates inflammation. And again, like the other comorbidities, that inflammation will lead to periductal fibrosis. On the lower sector, the iatrogenic ocular surgeries, that extends from things like LASIK as well as cataract surgery. All these can create inflammation on the ocular surface, which again can exacerbate or initiate Meibomian gland disease. The outer rings of this hub and wheel configuration above is systemic comorbidity, so non-autoimmune diseases, autoimmune disease, and iatrogenic. Iatrogenic in this category would be things like Accutane or anti-androgen medications for guys that have like prostate problems, prostate hypertrophy, or those that are trying to limit their hair loss. On the lower ring, the cofactors, things like stages of life, environments. So if you're in the Midwest or upper Midwest, or in Canada, for example, or California, you're exposed to frequent or the fires with smoke and poor quality of air, these particles are notorious for causing inflammation on the ocular surface, again, exacerbating and even initiating Meibomian gland dysfunction. Lifestyle and diet. In my experience, caffeine is not a good thing for dry eye for multiple reasons, as well as things like exposure to raw onions and so forth. And we can get into more detail later, but I want to give you this overview. So if you understand this, you understand that to get control of your dry symptoms, you identify the severity of your MGD, and then you identify the comorbidities. And by targeting the MGD, by targeting the comorbidities, you can get the symptoms under control.
All right, that's a great explanation. I think everybody, it's kind of self-explanatory. You can kind of read the wheel and see what is your symptoms and what's wrong with you if you have a diagnosis. I want to ask a question that Alan Chavez had asked, and I've been dealing with this a lot. Some of you know me, I'm a bit of a patient advocate, and I've been getting a lot of calls from young people. And I have a question from Alan Chavez, and he's asking, he's a 20-year-old male, and he's just been recently diagnosed with dry eye. And why are we seeing more of an epidemic on younger people?
Well, I think there are a few things. We know now that the increased use of screen time, our phones, monitors, computers, this stresses the ocular surface and creates inflammation just by the sheer number of hours we spend on our phones and monitors, computer monitors, because we decrease our blink. When we decrease our blink, then that's called gazing, but that in turn leads to inflammation in the ocular surface. And as we just said, inflammation, whether it be from any of the comorbidities that I reviewed on the wheel, as well as a frequent computer use and screen time, leads to that inflammation, which ultimately exacerbates MGD.
Okay. I have another question on diagnosis from GS Vinci. the best approach in order to treat meibomian gland dysfunction. What is the protocol?
Well, the best way to treat MGD, I think, can be understood if we look at Claire, if you could put up the image of the periductal fibrosis. And it's so important to understand what I consider the proximate cause of meibomian gland dysfunction. When we talk about meibomian gland dysfunction, of course, the most common cause of MGD is obstructive MGD or hyposecretory MGD due to obstruction. And the obstruction is from this periductal fibrosis, which I show in this paper here that we published, I think it was 2019. And what we see here in A, this is a image from confocal microscopy of the lid margin. And when we do confocal microscopy of the lid margin, we see these orifices. This is an orifice in A of a meibomian gland orifice. The empty arrow, the hollow arrowhead points to the lumen, or the channel through which the oil flows to reach the lid margin. When we blink, that oil now on the lid margin can be delivered into the tear film. So it's important to keep that channel, that lumen, open. That lumen is surrounded by the duct wall, seen there. And then we see at 12 o'clock and 2 o'clock to 3 o'clock, these sheets of scar tissue. As we go deeper in the lid, now mind you, this is at 67 microns. So this is very superficial at the lid margin. As we go deeper in B, this is the same gland, just going a little deeper to 112 microns. We see that scar tissue has now organized into a tight belt, circumferential belt around the orifice, and in turn chokes off the flow. You see the lumen now is obliterated. You don't have that dark, nice, round, big, large center. It's now obliterated. And so that scar tissue, the organized scar tissue, is choking off the flow. And therefore, the oil is still being secreted behind that choke point, but it builds up. And when it builds up, it increases the pressure behind that choke point. And that's often manifested as lid tenderness, okay? The scar tissue could also appear, I can see, as a focal disruption of the basement membrane of that duct wall. And you can see that in the black arrow at about 4 o'clock in C, focal disruption. So what I'm trying to convey is the essential concept of periductal fibrosis. We found it and we reported and published it in this paper. Over 90% of glands in lids with MGD have periductal fibrosis at some depth of that gland, over 90%. So you asked about the best way to treat it. Along with lid hygiene, which, just simply keeping your lids clean and healthy on the surface, these foci of periductal fibrosis, which are often occult and not recognized, are essential to release, to allow the restoration of the integrity of the ductal outflow tract. And if I could take the opportunity, Claire, to put on another slide, I want to emphasize also, this is the graphic showing that periductal fibrosis, which you've just been talking about, can be identified at different depths of the gland. This is, again, such an essential concept, which I find lacking. We're going to start, this is a 6-figure or 6-image slide, but I want to begin with the bottom left, CDO. Let's start there. In this gland here, CDO stands for complete distal obstruction, okay? In this case, there's a ring of scar tissue right there, just inside the orifice. Now let's back up a little bit. That oval, that horizontal oval is the orifice. The horizontal line is the lid margin. So in this graphic, that ring just above the orifice is a scar tissue. All right, so nothing's getting through there. Now, just above that, there are outpouchings, and those outpouchings are called acinar ductal units. In this graphic, those acinar ductal units are the sites where meibum is synthesized and then secreted into the central duct, and it flows down the central duct to emerge at the orifice. So when we have that ring of scar tissue choking off the flow just inside the orifice, nothing gets through. As we mentioned, pressure backs up, oftentimes manifested as lid tenderness. If that scar tissue is not released, then the entire gland will undergo atrophy. We call it whole gland atrophy, okay? The orifice may be remaining, but we lose the acidoductal units, okay?
I got it.
Now, it's important to understand that that scar tissue, in this case, that scar tissue will block any expressibility of the gland. But if the scar tissue is in a different location, let's say it's deeper in the gland, if you look in the top row in the middle, so-called CPO, okay, this gland shows the scar tissue deeper in. We call it proximal, right there, beyond at least one row of acidoductal units. So, and this is the key lesson here, the key concept. You put pressure over this gland, you find that the gland can express because there are acidoductal units in front of that scar tissue. And because there are acidoductal units in front of the scar tissue, that gland will be expressible. And the mistake that's unfortunately all too often made is that gland is assumed to be normal because there's meibum that's expressible. However, that's not the case. That gland is only seemingly healthy. It's actually sick with scar tissue. And again, it's unhealthy. And if that scar tissue is not released deeper in, well, then the part of the gland behind it will undergo atrophy, leaving a short truncated gland. And there's the short truncated gland. What's left over as we lose the more proximal piece. So we go from a full gland to a short truncated gland if we don't release the scar tissue when the scar tissue is proximal. In the case where the scar tissue is distal, just inside the orifice, we can lose the entire gland.
So, Doc, let me ask a question. Let me talk to you about this, just so I understand it, because it's been a lot of controversy on all of the sites, on the Facebook sites that I visit and I frequent. Is I tell my own story, and my story was that I wasn't producing any meibum when I first saw a local doctor, and he was an IPL doc. And he had given me I started my first round of IPL, and I did 6 or 7 IPLs, and he would express me after my IPLs. And I think I understand with what you just told me, and it's something that's out there that really needs to be addressed, because people have a big misconception about this. And what I've learned, and correct me if I'm wrong, that the IPL was helping express oil when I had a CPO gland, because it was heating up and producing oil from the lid margin to the ductal fibrosis. But behind that, my gland was still dying off and becoming atrophic, because the IPL will not clear the obstruction. Is that a correct statement, Doc?
Right. Now, the IPL is not designed to clear the scar tissue. And the problem is when you use heat or pressure in the setting of a choked off scarred gland, you're going to increase inflammation. It can be somewhat confounding because patients can, after that treatment, some patients can feel more lubrication at the same time they feel more inflamed. And the reason is because, as you pointed out, in those glands that are CPO glands, there is material that can be expressed, and that material that's expressed with the use of heat and pressure treatments, meaning expression and heat, can lead the patient to feel more lubricated. At the same time, though, it's creating more inflammation behind that scar tissue. And so the lid can feel more inflamed, at the same time it feels more lubricated. So it's important to understand that really in my opinion, the first basic approach in managing MGD is to release the scar tissue and restore the functionality, restore the integrity of the outflow tract before complementary procedures are considered. Otherwise, again, we're increasing inflammation, which in your case, as you point out, led to some, basically returned you back to the pain that you were suffering before. So it's important.
And just so everybody knows, what I went through and what's brought me into this was I had 8 IPLs, and that was prior to me finding Dr. Maskin. And I found Dr. Maskin, and I was probed, and my lids were very tender to the touch. And once Dr. Maskin had probed me, the tenderness went away immediately. And I preached this to people on the site. And I also and then I thought I knew better. So I'm kind of a guy that more is better for me. And I went and I had IPL again after my probing. And the doctor had done expression on my eyelids with the forceps. And after 2 more IPLs, I was on my 9th or 10th, my eyes were just as bad as before I started to see Dr. Maskin. And I had to book a flight and fly down and see him and ask him for help. And from my understanding, as he had explained to me, was the expression pretty much was the culprit. Is that true, Dr. Maskin? Can you explain that?
Expression can raise intraductal pressure. So if there's residual, if there's blockage there in the gland, then the pressure will increase inflammation further and create more symptoms. There are studies looking at therapeutic expression, and they found that it would take 5 up to 7 psi to evacuate a meibomian gland. 1 psi is 50 millimeters of mercury, which means 5 to 7 is up to 350 millimeters of mercury. As we know, systolic blood pressure is normally about only 120 millimeters of mercury. So when such great force is being used to try to squeeze out the meibum, it can be, in some cases, we thought of as applying a tourniquet to the gland. So you can actually shut off blood flow potentially when you have such high pressures. And there's a potential for what we call the perfusion-reperfusion syndrome, which can create inflammation by, again, closing off the blood flow and then releasing that. And so, it's very careful when you do expression to be gentle. In my setting, after I probe, I do gentle expression, gentle. I don't apply, I don't apply significant force at all when I gently milk out the material that was trapped behind the scar tissue, very gentle. In my opinion, one has to be very, very careful about the amount of pressure one uses. But the point is that there's a tendency to use a lot of pressure because of the scar tissue there. And so when one's accustomed to doing that, then again, we're creating excessive inflammation. I would just use very gentle pressure. And if it requires more than that, then there's still some blockage, maybe deeper in the glands that hasn't been released from I'm talking about scar tissue that still hasn't been released.
Perfect. So we kind of morphed into the second heading of probing. We're already have been discussing probe, and I have some questions that were brought in about probing. We handled the best way to treat meibomian gland dysfunction, and that kind of started us off in the topic of probing. And I have a couple of other questions. How do I know if I'm a good candidate for probing?
Well,
it was a very popular question.
As we showed in our paper published 219, over 90% of glands in lids with MGD have periductal fibrosis. over 90%. So my answer is, if you have MGD, then you're a good candidate for probing. Aside from lid hygiene, aside from keeping your lid margins clean, probing, in my opinion, should be the first thing done to release that scar tissue, to restore the integrity of the outflow tract of the Meibomian glands. And so that would be the first thing I would do. So are you a good candidate? You have MGD, the answer is yes. And if you remember from the hub and wheel, if you have Sjogren's, for example, if you've been diagnosed with Sjogren's syndrome, which means very poor aqueous MGD. And don't forget, symptoms of MGD may be not present until far along the disease. That's another problem. Patients sometimes come in with symptoms and they're astounded to find with meibography that such loss of tissue, because the disease can progress in an asymptomatic manner. I might want
or it can progress. Like from my experience was, I didn't even know what it was. All of the doctors I saw didn't let me know that what MGD was, and I just was treated for my aqueous tear deficiency. Meanwhile, all of my glands were becoming atrophic. It wasn't up until 8 or 9 months after suffering where I finally found a doctor that did a meibography on me. And I said, oh my God, what are those things? And why don't I have them all?
Right.
You're seeing in your local optometrist, and he's putting plugs in your eyes and kind of moving you on down the road that way, trying to help you, just because he doesn't know any better.
It is important. It's very important to identify and treat aqueous tear deficiency. Whether your preference is plugs, my preference is cautery. I can modulate the size of the opening to optimize the amount of moisture. But it's very important to make that diagnosis of watery tear deficiency. Obviously, it's important to make the diagnosis of MGD as well. But again, I want to come back for a second and just talk about the comorbid diseases. So patients, since we're talking about probing, if you're a patient that's been probed and within 2 months you have symptoms return, that tells you right off that there are undiagnosed comorbidities. Probing should not be necessary more than once a year unless you have a severe autoimmune disease, for example, that is not being brought under control with systemic therapies. But probing is not a procedure that you should need more than, as I say, once a year. And if you do find that within 2 months of probing, you need to be reprobed, there's a missing comorbidity that's not been identified, or if it's been identified, it's not been adequately treated. So keep that in mind, those of you that have been probed and you're finding yourself having to be reprobed, with some frequency. It's really not necessary, in my opinion and experience.
And a tremendous misconception is that I talk to people, they say, if I could just get probed, I'd be better. And it's so untrue.
No, that's a great point. Probing does what? Okay, I'm trying to review this over and over again. Repeat. Probing restores the integrity of the outflow tract of the Meibomian gland. Now, there is more, and that actually does more than that. So it releases the scar tissue for the full length of the gland, but we now know it also activates the precursor cells of the Meibomian gland ductal epithelium. This is some of our relatively recent research that I've already presented at meetings, and this is very exciting. So it actually stimulates the gland both at the full length of the gland, I should say, by restoring the outflow integrity, but it stimulates the precursor cells, which are located at the lid margin. So it's very important to understand.
A precursor cell. Give me that.
Okay.
Give me that.
A precursor cell is a cell that hasn't yet, just like stem cells, it hasn't yet committed to a pathway. So a stem cell or a precursor cell ultimately, as it matures, it may become a muscle cell or a cardiac heart cell, or in this case, it may become a meibomian gland epithelial cell. It hasn't matured, so it's still an immature state. It has not become, we call fully differentiated. So these cells, these precursor cells in the meibomian gland, we found evidence at the lid margin that they occur in structures at the lid margin, and we've reported this, and we found that the active meibomian gland probing activates them and leads to increased duct wall thickness, increased epithelial cell layers, and we continue to research in this area. We're finding some very exciting things, and we can.
So it doesn't know what team it's playing on yet, and then it picks the meibomian gland and it regenerates
Well, in this
itself.
case, because of its location at the lid margin, it will become a ductal epithelial cell, but it hasn't begun the process. So its stem cells are waiting to be activated. They're sitting there waiting to be activated. Once it's activated, then it will start dividing, and the daughter cells, we call those, that act as proliferation. Those daughter cells will migrate along the meibomian gland duct proximally away from the lid margin. So the same way, for example, if you scrape your skin, okay, these stem cells in the skin surrounding the area you scrape will start dividing and migrating. They proliferate, they'll migrate over the area that you scrape to heal it. The same thing, if you stimulate the meibomian gland precursor cells, they divide. The neat thing is, as we've shown, the active probing remains in the epithelium, meaning that in fact, we're kind of moving on to like a regeneration topic. Claire, could you put up a?
I have one or two more probing questions,
We'll
and then let's go on to the, so here's a big one. Like, how does everyone know that they're a candidate for probing? What do you do when the glands are too scarred and blocked to be probed, or the probe breaks when trying to insert?
Yeah, good question. First off, it's important to that your doctor use the 1 millimeter probe. We have 124, and we'll have 6 millimeter probes available in the future. But these probes start with the 1 millimeter, and that's the shortest and stiffest, most likely to find the correct entry angle and successfully enter through the orifice into the distal duct. We also are planning to have what's called dilator probes. The dilator probes are thicker than the basic probe, and therefore they'll be able to get through very, very, very dense scar tissue. So actually, your doctor should, so they're ready to release the scar tissue in any case, of the severity of that periductal fibrosis.
All right, and so just to wrap up our probing topic, because a lot of people have that misconception that because your glands are atrophied or missing, that you cannot probe them. That again is a misconception, because I know this for a fact from my own meibomian glands, is that I was missing glands, and Dr. Maskin, you were able to probe them and get them working, and I have pretty much all my glands and all of my uppers and lowers working, and they were gone. They were gone on the meibography.
It's a great question. It's important to know, and we published this, and maybe Claire, if you could put up the picture of the probe in the whole gland atrophy case.
Yeah, and that'll lead us into our next topic, which is the meibography.
So here we have a meibography. This is lower lid. In A, you can see the probe inside the gland itself. Claire, if you could show that, or put an arrowhead on that. I drew a line. We put a line. You see the black line that we put parallel to the probe. So the probe is right there. Thank you, Claire. And then next to it's a black line that we put there just so the viewer can see what we're talking about. So you can see how the probe is inside that duct of a gland that has undergone atrophy. It's really a whole gland atrophy case. The point here is that you can have cases where there's whole gland is atrophic, but the orifice remains. If the orifice remains, that suggests that there's still a duct there. And so that gland, though, that orifice should be probed. And you can get into the duct, and by doing that, you release the scar tissue, because you'll find, again, that there's scar tissue around that duct. So if there's an orifice, doesn't matter if there's no gland visible on meibography, these are meibographies, you still should have those orifices probed and release the scar tissue. You don't know, looking at this meibography, there may be a few cells that are still there that are capable of synthesizing meibum, let alone putting aside the whole notion of regeneration. Just the fact that there may be cells there that are so, because there's such a small population, they still may be there. So if there's an orifice, you probe it and you activate those residual cells. And again, regeneration is another thing entirely we can talk about later, but do not miss the opportunity. You want to optimize every gland you have. You never know when you're going to get, for example, a chalazion, a hordeolum, and wipe out the glands in an entire third of a lid. It can happen, as everybody knows, quite quickly. So you want to salvage every gland you can.
And I try to express my feelings of that to people that I speak to on the site, that please, time is of the essence when you're first suffering. Have a meibography, get into a doctor that understands the disease and offers probing as a first line of defense to restore the ductal integrity of the gland so it can become healthy again. And people fight me on that and say, no, I just booked 10 IPLs. But that's a whole nother topic.
Like we've talked before, if the glands are treated with pressure and heat, pressure meaning expression, and heat prior to releasing the scar tissue, in my opinion, you're increasing the inflammation of that gland, of any tissue behind the scar tissue. And as we've seen, the scar tissue could be at different depths of the gland, so it could be exacerbating the problem. So always release the scar tissue first, in my opinion.
Right. And a good question was, can you tell from a meibography if you have restrictions in your glands, if the glands are blocked from simply a meibography?
No, you can't. You can't tell on meibography if there's scar tissue. You can tell, for example, we showed an image earlier today of confocal microscopy. You can see scar tissue on a confocal microscopy, but meibography does not show that. Thank you, Clara. There you see the periductal fibrosis in B is best demonstrated there. So the best way actually to show fibrosis or to identify the presence of fibrosis is probing. Probing is not just therapeutic, it's also diagnostic. And when you probe a gland, then you know exactly the nature of the obstruction. Is it fibrosis? Is it, we call that firm? Could be firm gritty, which means multiple levels of scar tissue. Could be firm pop, which means just one foci, one level of scar tissue. It could be soft, which means there's more of a drag on the probe as it enters into the duct, central duct. It's more of a drag, as though there's some abnormality of the duct wall, or maybe thick meibum. And then there's some times where you have no restriction, no obstruction, no resistance at all. So probing is diagnostic, and you can get a sense of how much firm resistance, how much fibrosis is there by probing. And so, as I said, going back, if you have a patient with MGD, the best thing to do is is to probe, because you'll find, again, 90% of those glands have some level of scar tissue in there at some depth of the gland. If I can real quick, Claire, could you put up the slide showing the probe in the different glands, just to give a sense of, so in here, this just shows, and again, this is published material, but I just want to show people to understand what this is like. This is a probe in A. I don't know if you can zoom in or not, but the probe is inside the central duct of this gland here in A. Thank you, Claire. Okay, so that's a 1 millimeter probe. In B, if you scoot it over, if you look carefully, you can see aconite on top of the that's good, on top of the gland, just confirming it's actually in the central duct. And then you scoot back out, and C is a 4 millimeter probe right there. Okay, and D is a tube. D is a tube, and there I am lavaging the inside of the glands with corticosteroid. So that's a tube, and again, we're just rinsing out, which helps two things. One, it helps clean out the residual debris after I probe. It helps clean out the residual debris after I probe and gently express, and also delivers a pharmaceutical to the inside of the gland. So I just want to take an aside and show that it's very important information. So we're really treating the gland from the inside. And again, it also shows, again, the fact that we're in the epithelial compartment of the gland. And we'll get to that later when we talk about regeneration, but remain in the epithelial compartment, which is the regenerative compartment. So we do not create any scarring from the procedure, because again, we're in the regenerative epithelial compartment.
And that's been brought up a lot too, and I've actually had a doctor say to me in my infancy stage of my disease is, oh my God, when I first learned to probe, and said, oh my God, I would never probe anybody. That's too invasive. You could cause too much damage.
That's like saying, why I shouldn't rub the back of my hand where it itches. I'm creating damage.
People don't understand that. They think that it's a probe going in and it's going to puncture or damage or something. But that's been a question from a lot of people.
Whenever you're ready, we'll show the image of the gland, with where we talked earlier about activating stem cells and increased duct wall thickness. When we show that, we can show how the epithelial compartment. We can talk more about that.
Let's go into regeneration. Can an atrophied cell, can atrophied meibomian glands regenerate?
Okay. This is also from a paper that we published in 2018. A and B, that case is from that paper. C and D, I presented at meetings. This is after probing. Let's start with C and D, actually. Everyone knows that these are confocal images, confocal microscopy images at the lid margin of the meibomian gland orifices. A is pre-probing, and you can see the duct wall thickness in C, and then post-probing is D. You can see there's about a 30%, I think 30 to 35% increase in duct wall thickness. This is at about, I think, 1 to 2 months post-probing. So this is very exciting that we're able to do this, and we have subsequent work. We actually show this, again, the precursor cells and how they activate to generate this type of reaction or response. This is a paper that's we've submitted for publication. So the point is, when we probe, the probe, it goes into the lumen. So again, show the lumen. So it goes into that lumen. This is all epithelial. This is the epithelial compartment. When you're in the lumen, or even in the cells surrounding the lumen, the epithelial cells immediately surrounding the lumen, those are old cells. Okay, the meibomian gland duct wall, the younger cells are toward the periphery at the basement membrane. And Claire, if you show the basement membrane is this outer wall of the Yeah, that's the basement membrane. Okay, you can right there is good enough right there. And then so the cells just inside there, just point to it. The cells just inside, yeah, those cells are young cells. As they mature, they migrate to the center toward the lumen. So those are older cells in this around the lumen right there. So that when you probe, we're in the lumen and immediately surrounding. So we actually are debriding the old cells. When we probe, we're not just dilating open the lumen, we're debriding the old cells, the old senescent cells. And again, that process activates the precursor cells to proliferate. So, but this is all the epithelial compartment. Okay, this is in the epithelial compartment. Therefore, it does not lead to scarring. In A and B above, those are my biography images, of course. And what we show here is pre-probing is A, and you can see inside the oval, we've just kind of focused on that area, the lack of gland tissue, and then compared to B, you can see that increased gland tissue in B. It's pretty obvious. So we've seen that this is at a retrospective study. We show that 40% of lids that were probed showed signs of regeneration on my biography. So this is an active area of research. As I said before, we've already identified the precursor cells, and we've identified the probing activates those precursor cells as well as clear the entire duct outflow tract to restore the functionality of the glands. So this is an active area of research for us, and we're very excited about where we are and where we're going.
Dr. Maskin, you never disappoint. I told you, he's not just another pretty face, folks. So let's move on to another topic, my all-time favorite, aqueous tear deficiency and punctums and how you treat that. When I first was diagnosed with this, I had collagen plugs put in my puncta, and it didn't work for me at all. And then I moved on to silicone plugs, all local. That was worse than my my dry eye symptoms because it always rubbed and oh my God, it was a terrible time in my life. So go ahead, Doc. Explain aqueous tear deficiency and how you treat
going
it.
back to the first figure, aqueous tear deficiency is a major comorbidity. Aqueous tear deficiency, allergy, anterior blepharitis, those are major comorbidities that create inflammation that initiate or exacerbate MGD. Very important to get a handle on that. In the case of aqueous tear deficiency, I for one like to use punctal occlusion. So I like to close the punctum. The punctum, of course, are those portals in the inner aspects of our lids that take the tear into the nose from the tear film. It is there are different ways to occlude the punctum. Many doctors like using plugs. I'm not a fan of that because of the multiple problems I see with plugs. They fall out, they can scrape the ocular surface if they don't fit just right, they can migrate deeper in and cause inflammation, scarring in the canaliculus, that duct that leads into the nose. For me and my patients, I find that punctal thermal cautery works beautifully. I do it superficial, so I have an excellent chance of dilating it open a little bit if we have a patient who winds up with too many tears. So we have some ability to control the opening and the amount of tear. LASIK patients are classic. Post LASIK patients typically, I would say they often have aqueous tear deficiency as well as MGD. If you close, for example, the lower punctum on LASIK patients that have ATD, it's typically not sufficient because again they lose that neural connection due to the LASIK procedure itself, and so they're not talking. The surface of the eye is not talking to the tear glands very well, and oftentimes I find that closing the lower punctum alone is not sufficient, so I partially close the upper one, and that combination has proved very effective in controlling the aqueous tear deficiency in those LASIK patients. But every patient, again, it needs to be individualized. But that was an early experience that led me to the conclusion that it's important to be able to control the amount of moisture or tear that exits through those punctum. And sometimes partial occlusion is important. Therefore, we must do it superficially, the punctum treated superficially so we can adjust it if necessary, without a foreign body in the punctum. I prefer not to avoid that foreign body.
And people that I've spoken to were very, very concerned, and were afraid of this and the cautery. And as Dr. Maskin puts it, 3, 2, 1, it's a little bee sting. And yes, it is.
I want to point out one thing, because oftentimes patients come to me with this notion that they can't close the punctum because of what's being called toxic tear syndrome. Each patient is individual. I've been doing this. I've been doing punctal thermal cautery since the late 1980s. It is exceedingly rare to have patients that get toxic tear syndrome. You get inflammation on the ocular surface simply by not having enough moisture. Not having enough moisture, not having enough watery tear creates inflammation. So my patients, I close their punctum to get adequate moisture, and then I have them irrigate their eyes to remove irritants and pollutants that get into the tear film. There may be one patient over the course of 3 decades that I've felt that may have some irritation from excess tears and the retention of irritants. But that's a patient, again, that was unable to irrigate properly, and they had their own personal reasons why they weren't able to do a good job of irrigating themselves. So I find that the greater good is in providing more moisture. Just like we talked about with saliva and teeth. You don't have enough saliva, you're gonna have tooth decay and gum problems. Ocular surface, you're gonna have more problems if you don't have enough moisture. There are ways to handle it. You can always open the way I do it, the punctal occlusion. I can always open, most always, never 100%, but most always open it in the exam room, okay, to reduce the amount of moisture if that's necessary. But that with a combination of irrigation, this toxic tear problem is a problem that I really not have had it seen in my practice.
And the toxic tear, meaning that because your eyes don't get flushed with your tears and draining, the tears remain in your eyes. And I know from experiences, because I always work in a very bad environment. So what I do is I irrigate with saline. I have punctal occlusion on all 4 of mine. And at one point in time, what Dr. Maskin was talking about is he finds the sweet spot. Meaning at one point in time, I was producing too much tears and my eyes were raw from it and spilling over. So he could go in and open some of my puncta to let it drain a little bit more and find the medium where my eyes need to live. At this point in time, I have most of mine closed, and I just irrigate probably once or twice a day to flush my eyes, because I'm always in a corrosive environment, being I work construction.
You take an example, you take an example like a patient with rheumatoid arthritis and Sjogren's, where they make next to no tear at all, no moisture at all, or very little. If you don't preserve the little moisture they have and hopefully accumulate to some level of significance, you're at risk for significant problems of your cornea, corneal breakdown, ulceration, infection, and loss of the eye. Or you could go to the route of scarring. You can basically have your corneal scarred, corneal fibrosis, and require corneal transplants. Either way, it's important to have enough moisture.
All right. Yep. I think that covers that pretty well. I think between the both of us, I dumbed it down so I could understand it. Let's touch on neuropathic pain and ocular surface. How do you tell dry eye problems from corneal neuropathy? Big question. There's a whole Facebook group that is all about corneal neuropathy.
I published a paper last year, 2022, that Claire will put up on the screen. And this is a paper in American Journal of Ophthalmology case reports. It's a case series. I felt I had to do this because I frequently see patients with diagnosis of neuropathic pain come to me for help. they're often suicidal. I get patients come to me about every other week that are suicidal. And these, inevitably, these patients wind up with having what I call occult ocular surface disease. In other words, disease which has not been recognized by their diagnosticians, by their doctors. They haven't recognized. Classic is MGD. So neuropathic pain is diagnosed, generally speaking, so-called cases where there's pain with no stain. What that means is that the patient has pain. However, if you stain the ocular surface with vital dye like fluorescein, you don't see any staining patterns suggesting unhealthy cells. And these cases, so pain without explanation for the pain, is something that suggests neuropathic pain when reading the literature. And on top of that, if you add anesthetic, a topical anesthetic drop, these patients that are given this diagnosis do not have a diminution in pain. They still have the pain despite the topical anesthesia. The problem with that, gland disease, Meibomian gland pain, periductal fibrosis, and the pain associated with it is not anesthetized with a topical anesthetic drop. So in other words, you could put a drop of topical anesthesia on the eye, and if the cause of the pain is MGD, the pain will not go away. And patients are being told that, well, you have neuropathic pain, so therefore it's nothing caused, the pain is not caused by your eye, it's caused by the autonomous firing of central nerves. It's in your central nervous system, and that's where the pain is emanating from, because of previous past pain that has gotten so severe and so chronic, it's created it's created or stimulated nerves in the central nervous system to cause the ongoing symptom of pain. What I'm saying is that in my experience, the patients that that I see here in my practice, given this diagnosis, I've been able to identify unrecognized ocular surface disease, whether it be MGD, which is classic, okay, particularly when there's deep fibrosis, like 2-4 millimeters, deep fibrosis, where again, the glands, remember from the beginning, the glands are expressible. So the doctor thinks that everything's normal, glands are expressible. No, there's deeper fibrosis, and that's creating severe pain. It's not recognized. So I've been able to identify again. So the other thing is, Claire, if you go back to the that paper and the figure in that paper, another cause of unrecognized pain is chalasis. And I want to show there. Now, this is an example of superior chalasis. That bracket shows a small area of chalasis. Now, the chalasis in this patient is much more significant, much larger. And by chalasis, I mean this loose tissue there. You can see like a bubble of tissue there. It's much larger, but what I want to show here is the hemorrhage. The hemorrhage, you can see that horizontal hemorrhage there, and there's a vertical one, this vessel there, it's hemorrhage. So these hemorrhages can occur with chalasis because of the friction of the lid grinding over this loose tissue. So again, these are little clues. There are clues that can be identified with a rigorous examination that you can therefore reverse symptoms of patients that have been given this diagnosis. So so it's very important, again, you know, to have a rigorous diagnosis, to look at Meibomian glands, look at chalasis, look at aqueous tear deficiency. It may not be obvious. That's why I call in the title of this paper occult, because it's not obvious. But again, in my experience, we've had great success in helping these patients.
So let me just recap that so I can understand that. It's kind of like an amputee, right leg amputee has pain in their right foot, right? So it's pain that's generated in your head, but there's really no foot there to have that pain in. that's how it was explained to me when I had gone to a doctor, and he said that, you're feeling this pain, but there's really nothing wrong in your eye. And he had put me on a drug, pharmaceutical called gabapentin.
Yeah, so gabapentin is frequently used in this setting when there's no, if a doctor cannot identify the underlying cause or the cause of these symptoms, then if the patient is diagnosed with neuropathic pain, they put on gabapentin. The problem with that, in my view, again, is that gabapentin, number one, because it reduces the level of sensitization of the ocular surface, can actually lead to drier eyes. If you test it objectively but the patient may not have, the patient's symptoms may be reduced because they have a decreased level of sensitization. The other thing that I've had patients tell me that because of that reduced level of sensitization, which occurs with the entire body, one patient almost fell down the stairwell. Another patient bit into a baked potato, didn't realize it was so hot until they burned their tongue and steam came off their tongue. So it really, we have to be very careful when prescribing this medication to patients. We truly needed to have a rigorous examination done, spend the time necessary with these particular patients that have this diagnosis, because their disease may not be as obvious. So they in particular need extra time to identify those occult meaning non-obvious causes of their pain. So they're not placed on these medications unless they absolutely have to be on them.
Right. And yeah, and that's what I was. I felt very numb, completely numb throughout it. And I tried gabapentin for a while, and that's how it was explained to me, is that my nerve path has to be redirected. Yeah, it was a horrible experience. So we touched pretty much all of our topics that we wanted to touch on. We didn't get to everybody's question, as I explained that there's no possible way we could do that in an hour. We're hoping to do this again. I hope it helped kind of clear up the path of dry eye. And again, we have to find a different name for it, because if anybody out there suffered as I did, dry eye just doesn't explain it. That's a little humor on my end, but I guess we're looking to wrap up, Doc, unless you have anything else to say.
Well, the only thing I would say is my message is hope. As I mentioned, my goal in being with everybody tonight, each of you, is to try to point you in the right direction. All right, to try to point you in the right direction by giving you the basic concepts as I've learned over the years how I can help my patients, and sharing these basic concepts, whether it be in my book or with my individual interaction with my patients when they're here, or a forum like this. If I can point you all in the right direction, then I'm hoping that'll help you find the answer to the solution for you. There is a consistency of how to look at these problems, how to manage these problems. Again, we find out the severity of your MGD, identify your comorbidities, and you use targeted therapy. So important, use targeted therapies. If you use non-specific therapies, non-targeted therapies, those diseases will continue. So if you use a non-specific treatment, like a topical steroid or other anti-inflammatory, and you have allergic disease, or if you have an infection, or you have aqueous tear deficiency, if you're using a non-specific treatment, you may feel better, but that disease will progress. Your Meibomian glands will progress, their disease will progress. It's so important I can't emphasize this enough, identify the specific disease and target it with specific therapies, not general non-specific treatment, because the disease will progress. Your gland atrophy will progress if you monitor it. So pointing you in the right direction, the message is hope. Okay, the most significant factor to achieving lasting eye comfort is understanding the disease. Dry eye MGD. The patients I see, as I mentioned before, they come to me, they're suicidal or near suicidal. They've tried everything and failed, and I'm their last hope. Their concepts of dry eye and MGD are wrong. They've been misinformed, misled, and they're confused. Yet by the end of our evaluation, they're amazed what they've learned about their individual cases. It all makes sense to the patient, and they're amazed how fast they can recover and restore their eye comfort. It is a lot, because when patients typically come to me, Matt, they haven't learned any of this. They don't know any of this material, and it can be overwhelming. The amount of information they've learned about themselves and the concepts that they use to successfully restore comfort is all fresh. It's all new to them. So it can be overwhelming to the patient. But the most important point is, again, keep hope. There's a way to manage these problems. And again, hopefully I've given everyone a path, pointing in the right direction, how to think about this disease. And I wish everyone well. Keep your hope.
Thank you, Dr. Maskin. And I just want to say, I get a little emotional about this, but it helps me because it makes my eyes feel better. But Dr. Maskin saved my life because I was suicidal when I met him.
Matt, you weren't here earlier when I thanked you. Again, I think it bears repeating. You are the driving force behind this event. Everyone should know Matt has an enormously large heart, and he's determined, as I think everyone can see, he's determined to help as many dry eye sufferers as he can. So everyone, really, I'm sure that everyone listening to this presentation is very appreciative of what you do, Matt. And
thank you.
You're making a difference in the world. So just so you know.